Welcome to the lecture on urinary tract calculi. Other words that we use for urinary tract calculi are nephrolithiasis or kidney stones, and we're talking about the same thing with all of those words that we use. And so kidney stones are, again, fairly a common disorder in the United States, with 1 to 2 million people yearly diagnosed with nephrolithiasis. It's usually more common in men, and that's for most kidney stones except for the ones of the struvite makeup or variety. And the average age is between 20 and 55 years of age, so happening in our fairly younger to younger middle age individuals. It does have an increased incidence in people of white race. It happens more often in patients who have a family history of stone formation or a previous history themselves. So the recurrence rate is about 50% in patients who've had one. There's about a 50% chance that they'll have another in their lifetime. And it is more common to occur in the summer months, and this is because of the role that dehydration plays in the process of stone formation. There is no single theory for how these stones are formed, but there's a combination of etiologies, including metabolic, dietary, genetic, climatic, lifestyle, and occupational influences. Some of these factors are affected by urinary pH. So if the pH is too high or alkaline or too acidic, it can increase the solubility of different ions in our urine, such as calcium and phosphate are less soluble in an alkaline environment. So we're more prone for those calcium-forming crystals. The more acidic the pH or the lower the pH, uric acid and cysteine are less soluble, and thus we're going to be at an increased risk for those those cysteine type stones. When we have more solute than solvent, it's going to precipitate out, and so that's where those stones are being formed. Other factors like obstruction with urinary stasis can increase the risk of stone production, because that urinary stasis can lead to UTI. And some of these bacteria, when they go through their metabolism, they will split off urea, and that will contribute to the uric stones that have urea as their mainstay. As well as there is some genetic factors such as cystinuria, which is an autosomal recessive disorder, and there's markedly increased excretion of cysteine, which can get caught up and cause stone development. So the different types of calculi or stones are listed here. Another word for stone is lithiasis, which means stone formation. But either way, those calculus or the stone or stone development lithiasis, they all are categorized as different types of makeup, such as the calcium phosphate or the calcium oxalate, uric acid, cysteine, and struvite. The most common type of stone formation are those calcium stones. And calculi can be found in various locations in that urinary tract. And the struvite stones, those are more common in women than they are in men. The first symptom of a kidney stone is usually a severe pain that begins suddenly, and the patient is going to be very squirming, and they just cannot find a comfortable position. They are just moving all over the place in the bed, and it is a very colicky, type pain, so it'll have a very severe pain, and that's usually when that stone is moving and kind of cutting and causing damage in that ureter. And the pain is usually found in the back, flank area, or it might be in the lower abdomen. The most common sites of obstruction and where patients get those stones stuck is going to be at the ureteropelvic junction. And so if it is here, it's where the renal pelvis is connected to the ureter, so it's higher up in the kidney. So we're going to see more of that pain in the costovertebral angle or that flank region. We might have signs of shock with the kidney stone while it's moving and with that pain. And it might be accompanied by other UTI symptoms like those LUTS symptoms like the dysuria, hesitancy, pain with urination. But it's very common, again, to have kind of that flank pain, groin pain, and especially it's more colicky, so it comes and goes, but it's very severe and acute when the pain does occur. To diagnose kidney stone, non-contrast CT is commonly used with the patients who have renal colic. It's quick, it's non-invasive, and it has no contrast in it, so it doesn't have any other complications of the IV dye. Sometimes we can do ultrasound as another avenue to diagnose kidney stones. A helpful test to do is a urinalysis, and this can assess for blood in the urine, crystals in the urine, and it can assess the urinary pH to see if it's alkaline, acidic, or whatnot. The retrieval and analysis of stones is important because then we can diagnose the underlying problem that's contributing to that stone formation, as well as that's a definitive testing for kidney stone if we scan through the urine and get a stone out. We know for sure, oh, your pain is from a stone and now it came out, and hopefully you're feeling better. Other lab tests that we look for are going to give us ideas about, again, if there's what the stone might be formed of, and if there is dehydration that's playing into the reason for stone formation. So care for the patient with a kidney stone. For acute attacks, the main thing that we're going to do is to treat the pain. And so we want to manage the acute attack by treating pain, infection, or obstruction. And opioids like morphine or Dilaudid are used to relieve that colic pain and to relieve that kidney stone dance that they're doing. Sometimes Flomax is given. This is an alpha adrenergic blocker, so it's going to relax that smooth muscle in the ureter. So it's going to dilate the ureter so that the stone can pass through, into the bladder and relieve pain that way. So after treating acute attack and assessing for the cause of the formation of stone, our next step then would be we want to prevent further stone development, because we know that once a patient has a stone, it increases their risk for having another one. So we want to get a good patient and family history of the patient. So does the family have stone formations? Where do they live, or where are they from originally? Because there is a geographic component there with people in the southeast and southwest U.S. having the highest incidence of kidney stone disease. Are they active? Do they have intakes of vitamins A and D? Has there been prolonged immobilization that they've gone through, or are they at risk for dehydration or have signs and symptoms of dehydration contributing to the stone formation? And lastly, any surgery involving the genital urinary tract that could be causing those stones, especially like the infected kidney stones causing damage to the kidney. The treatment of struvite stones requires control of the infection, since that is where these struvite stones come from, is bacterial infection. So we would put the patient on antibiotics, and we might also add acetohydroxamic acid, and this works by slowing down the formation of the struvite stone by interacting with those chemical processes of bacterial metabolism. And lastly, if that stone cannot be removed, or it can't pass, or the symptoms aren't getting better, we may do surgical removal of the stone to help with signs, symptoms, and sequelae of the calculi. In the instance that we would need that surgical intervention for kidney stones, there are several reasons that we would do either lithotripsy, open surgical stone remover, or the endourology procedures. And that is if the stone is too large, so it's 7 millimeters or larger, it's too big to pass through the ureters, or if the stones are associated with bacteriuria, they're causing renal function impairment, or they're causing persistent pain, nausea, and paralytic ileus. A couple other reasons that we might go to surgical intervention versus medical is if the patient cannot be treated medically or they only have one kidney, then we would do surgical intervention. Some of the first surgical interventions we would do are endourologic procedures. If the stone is located in the bladder, a cystoscopy is done to remove these small stones. For large stones, we would do a cystolithopexy. A cystolithopexy. In this procedure, we use a lithotrite, which is a instrument that breaks up the stones. Then we irrigate the bladder, and these crushed up stones will flush out of the body. A last endourologic procedure we can do is the cystoscopic lithotripsy. And in this, instead of using a tool or an instrument to break up the stones, we use an ultrasound lithotrite to break up the stones. So using the ultrasound versus an instrument to break up those stones. And then again, irrigating and having the stones leave the body that way. A last type of procedure for stone removal as an endourologic procedure is called the percutaneous nephrolithotomy. And so that's going through the skin, usually in the back or the flank area, using like fluoro guidance, going into the kidney pelvis and then breaking up those stones again with that lithotrite or ultrasound or instrumentation, and then we can remove those stones through the tract that was made there, and then we usually leave in a nephrostomy tube, which is that flexible tube that kind of comes out the back, just to make sure that our ureter isn't obstructed. Complications, of course, include bleeding or injury to the adjacent structures and possible infection because we're doing an invasive procedure. Usually done in an IR suite, and then as the patient is passing urine and they're not having those LUTS symptoms and we don't see blood in the urine, then we can take that nephrostomy tube back out. Other procedures used for stone removal are lithotripsy procedures, which are all labeled here, and you can read about them in your book more. But the most common complication of lithotripsy procedures, whichever one we choose, is hematuria. And so often after these procedures, we put in a ureteral stent to help that broken up stone pass through the ureter and prevent buildup, which might lead to reobstruction. And antibiotics are usually also administered with these because of the risk for bleeding and infection from invasive procedures. A small group of individuals might need an open surgical procedure to help with stone formation, and this would be more of the complicated nephrolithiasis. And the type of surgical procedure used depends on where the stone is located. So it would be, on the slide here, nephro would be cutting into the kidney, pyelo into the renal pelvis, uretero into the ureters, and then cysto into the bladder to remove those stones. Nutritional therapy is always important, and especially with stone formation, since dehydration and diet has a factor in production of stones. So first off, to manage an obstructing stone, the best and easiest thing that we can get the patient to do is to drink adequate fluids and avoid dehydration. We don't want to force fluids, but we do want patients to intake a larger, than average for themselves amount of fluids, again, to reduce the risk of dehydration. So we encourage about 3 liters a day of fluid intake, and we hope that they're also peeing a high amount out, again, to kind of flush through that obstruction. So we want them to go about 2 liters a day. This high output is going to dilute the urine, prevent the re-obstruction and the reformation of stones, and promotes the excretion of those minerals which originally make up that stone. It is especially important to increase this fluid intake or teach about adequate fluid intake in patients that are at higher risk for dehydration. And that can include the patients that are very active in sports, live in a dry climate, do a lot of physical exercise, have family or personal history of stone development, and those that work outside with their job, and so they're doing a great deal of physical activity outside and doing a lot of sweating. Nursing management of the patient with a kidney stone is really focused on teaching the patient about lifestyle and dietary habits that can change to reduce the recurrence of having kidney stones. So again, this includes having good fluid intake and making a good amount of urine. So if we can intake about 3 liters of fluid a day and output about 2 liters, that's going to help reduce dehydration and maintain good fluid levels. Sometimes we may ask them to be on a dietary restriction. For example, if there's calcium oxalate stones, that we might have them reduce dairy, cheese, milk in their diet to reduce that, as there is a Table 4512 that has more information on nutritional therapy and foods to avoid for the different types of stone formation. And we want to teach the patient, of course, about the dosage and how to take their medications. Sometimes they can self-monitor their urine input, but a nursing management is in the acute side, in the hospital side, is to strain all urine. So putting a little paper hat in the toilet and making sure that we're straining all of that urine to catch the stone. That way we can, have a definitive diagnosis, but we also can send it down to the lab and get it analyzed to know exactly how to specialize our education for the patient. Ambulation is key so that the stone will move. We want to have the stone passed. So if they're walking and moving about and ambulating, it will help that stone move from the upper urinary tract to the lower urinary tract and out the body. So our evaluation and how we're knowing we're doing all the right things is maintaining free flow of urine with minimal hematuria, because as that stone moves through, we will have blood in the urine, but it shouldn't be frank blood, more on urine analysis, if anything. Report satisfactory pain relief, so using good opioid pain medication there. And understanding the disease process and measures to prevent recurrence. So going through, again, the places where we live, the type of work you do, dehydration, and family history. Thank you.